upon Dr. Jatinder Singh Bhalla for ELP, Concepts and Practical Applications.
Thank you, everyone. The topic I'm going to cover is effective lens position, the concept and the practical application of this concept. See, in earlier times, cataract was removed first and spectacle prescription given last. Today, we calculate the power of IOL first and cataract surgery is done afterwards. So, IOL calculation plays a very important role to determine the refractive outcomes after the surgery. Today, we can customize the power of IOL to achieve near planar results even in highly myopic or hyperopic eyes. But there are a group of patients we all know that who value their emmetropia so much that they are ready to pay any amount to achieve it. And after surgery, if you break news to them that they require spectacles after cataract surgery, they are extremely disappointed. So what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for 35%, followed by other parameters like axial length and keratometric measurements. So effective lens position is the most challenging part in IOL power calculation. And one of the goals today is to come up with the algorithms that help you to achieve near emmetropia. See, in human eye is a dual eye system. In any dual lens system, if the primary lens and the distance of screen are fixed, which in eye it is fixed, cornea is fixed position, and axial length is fixed, then the effective power of the system will depend on the power and position of the second lens. In human eye, in phakic, it is crystalline lens, but in pseudophakic eye, it is the power and position of the second lens, that is IOL. So imagine, what all we want is IOL should sit right in the center of the capsular bag, but it does not always do so. Now this actual IOL power is 21 diopter, but IOL is sitting much anteriorly in the capsular bag, so effective IOL power will be much more, that is 22 diopter. And if it is sitting posteriorly, effective lens power will be reduced, 21 becomes 20 diopter. Why it happens? Because preoperatively anterior chamber depth is different from the post-operative anterior chamber depth. This is because lens, crystalline lens, which is about 4 or 4.5 millimeter, is replaced by a lens which is less than 1 millimeter. So the anterior chamber depth changes, and that's why effective lens power, effective lens position of the IOL also changes. In 1950, when the first IOL was implanted by Harold Ridley, it had a refractive surprise of nearly 20 diopters. So let's go to the history of effective lens position. Initially, the term effective lens position was used by Holliday in 95 to describe the position of IOL inside the eye, and it was thought that the effective lens position is equal to anterior chamber depth. And so the first value which was used was 4.5 millimeter, then subsequently it was increased to 5.25 millimeter. There are some hurdles in accurate estimation of effective lens position because the older formulae, they worked on these assumptions. That is, shorter eyes and flatter K eyes were supposed to have shallow anterior chamber and shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and longer effective lens position. But Holliday told us that there are 9 types of eyes. Eyes with normal anterior segment, 80% have shorter axial length and 90% have longer axial length. Similarly, in eyes with normal axial length, 2% may have shorter anterior segment and 2% may have longer anterior segment. So the relationship between anterior segment and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formulae are bound to fall in short and long eyes. The initial formulae, they worked on basically 2 parameters, axial length and keratometry. But we all know 2 eyes with same axial length and same keratometry may require completely different IOL powers. This is due to difference between actual and predicted effective lens position. This was study published in JCRS, which was done by Holliday on 34,000 eyes, and they calculated the relative importance of various variables affecting IOL position, and they, in their study, axial length was found to be the most important factor, followed by other anatomical parameters. So let's classify the factors which affect effective lens position. There are anatomical factors, which I've already elaborated upon. There are surgical factors, which include size of CCC. IOL-related factors are also important: shape, length, flexibility, anterior regulation, then material of the haptic. So various formulas have various constants to take into account these which affect the effective lens position. SRKT, the older formula, had A constant. Haigis has A0, A1, A2. Hoffer Q and Holiday 2 have anterior chamber depth. Holiday 1 has surgeon factor, Olson has C constant, and Barrett has lens factor. What exactly is A constant? A constant is specific constant for each IOL, and value of anterior chamber depth is calculated by regression, and it is in the value of anterior chamber depth is incorporated into A constant, so indirectly it affects effective lens position. Optical method definitely measures it 0.2 millimeter deeper than the ultrasound methods. So factors affecting IOL constant are type of biometry used, axial length keratometry, IOL types, and surgeon factor. We all know about these theoretical and regression formulas. So the newer formulas, which are slowly replacing the older formulas, are Hoffer H5, LADAS, Olson, Barrett True K, Hill RBF, Kane, and many other new factors. The third generation formulae, they calculated effective lens position is equal to distance from the cornea to iris plane plus surgeon factor. ELP is dependent on the anatomical factors, but surgeon factor is based on the regression studies based on retrospective BAL calculations using different IOLs. Holiday 2 used 7 factors to calculate effective lens position, in contrast to the older formulas which are dependent on just 2, 3 or 4 factors. And these factors are not only axial length keratometry, but also anterior chamber depth, lens thickness, white to white, age of the patient, and previous refraction. There are mathematical methods available to interchange or intercalculate effective lens position depending on anterior chamber depth, surgeon factor, and A constant. Barrett Universal 2 formula, which has become most popular, it has effective lens position dependent on lens factor, which is then calculated by keratometry, axial length, anterior chamber depth, lens thickness, and white to white measurement. Hill RBF depends on artificial intelligence. Now if we compare Barrett and Hill RBF, both are current formulas, both are more sophisticated, and surprisingly both use different theoretical premises, but both give you reading which is within 0.25 diopter of each other. So what should I do? Should I use multiple formulas and then average the results? Douglas Koch uses this premise, but Holiday and Barrett says use specific formulas for specific situation instead of averaging. What is the role of intraoperative aberrometry? Intraoperative aberrometry, there is no accuracy limit of preoperative measurements, and it eliminates variability of various calculations and assumptions like refractive indices. Ray tracing, the ray tracing it uses different corneal refractive index. Now we are stuck at 90% accuracy within 0.5 diopter. We are not able to achieve accuracy more than this. Why? The limit is not the formula anymore. Limit is the least count. Precision limit for least count for keratometry is 0.25 diopter, axial length is 0.1 diopter. So these errors limit keep us at 90% accuracy. Can we achieve 99%? Yes, if we use newer formulas and use specific formulas for different situation. So these are various formulas where effective lens position can be calculated by these mathematical measures, but there are error in effective lens position in post-keratorefractive surgery patients. I will not go into detail. There is a role of ELP in multifocal IOLs, toric IOLs. So this is ELP square sheet, which if we have done mathematics in earlier times, you used to have quadratic equation AX square plus BX plus C, where X is calculated as minus B plus minus under root B square minus 4AC by 2A. So here you can actually calculate effective lens position if you are really interested. These are the accuracy limit of various formulas. You will find the most accurate formula. This is a study which is published in Clinical Ophthalmology in 2020. The older formulas in the first 5 are nowhere in the picture. The new formulas which are most accurate in shorter axial length, longer axial length, and medium range between 22 to 26 millimeter are Kane, EVO, VRFG, Barrett Universal 2 and Hill RBF. And nowhere are Haigis, Holiday and SRKT are in the picture. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. And by taking into consideration the individual ocular anatomy and converting values for effective lens position to the appropriate units, we can improve our accuracy level. So accurate estimation of effective lens position is the final frontier in accurate IOL power calculation, and newer formulas can help us achieve this. Just like in life, in cataract surgery also effective position matters. If same IOL power is placed more anteriorly, it behaves as a stronger lens. If same IOL power is placed in a more posterior position, it behaves as a weaker lens. Thank you everyone for your kind and patient hearing.
Thank you, sir, for that wonderful talk. Any questions?
Good morning, sir.
Yeah.
Fantastic presentation, sir. Just in a normal cases, not abnormal anatomy, what is, how are you approaching for to get this effective lens position in your practice? Any practical tips for that in your practice?
Yeah. In average eyes, all formulae will give you good results in average eyes. Problem occurs only in eyes with, in shorter eyes, less than 21 millimeter, which gives you maximum error. In longer eyes also, even Holiday will do well, SRKT will do well, but slowly and steadily I have shifted to just one formula, and that is Barrett Universal 2. You can also do Kane. All these formulas are free and available on the net. Just take your values, open Barrett Universal 2 or Kane formula, feed the values, and you get the IOL power. So there's no need to buy expensive equipments like IOL Master and everything just for IOL power calculation. Take your values, feed in, and you'll get the results. Problem occurs if you suddenly find there are some red flags, like axial length is long, but anterior chamber depth is less than average. That is eye which will give you error, because normally what we assume is longer eyes will have longer anterior chamber depth and shorter eyes will have shorter anterior chamber depth. But if there is a mismatch, you are bound to have errors. So better is use Barrett Universal 2 or other Kane formula and feed in, you can feed in lens thickness and anterior chamber depth also. It will improve your accuracy.
What are the factors of the lens, what you are considering exactly? Which lens, what it will give the result? You have mentioned about the lens also. Which lens you are putting? So exactly any tips related to that?
No, you have to just fill the A constant of that. Depending on whether it is ultrasound method or optical biometry, just fill in that. And Barrett assumes, these newer formula assumes you are doing optical biometry. So you have to be careful about what A constant value you are using. I use either optical biometry, and at some places if I don't have, I use immersion method. Immersion ultrasound gives you quite accurate results. So no need to feel bad about using ultrasound if you are using immersion. Applanation biometry, it's out. But if you are using immersion ultrasound, it will give you equally good results.
Thank you, sir.
It was very elaborative presentation.